So I use the word 3D fantasy surgery, vitrectomy for proliferative diabetic retinopathy, no financial disclosure. And all of us know diabetic blindness, the challenge, it's an epidemic happening, and every diabetic gets affected in some way or other. It's an incurable problem, and ocular symptoms too late, and prevention is better than cure. So you see, you just saw a patient where Dr. Cyrus showed, which is a fantastic surgery, how he created the opening and then seeing the cleavage. And you in India, you see so much of severe traction retinal detachment. And other indication will be non-clearing, which is hemorrhage, and combined traction and rhegmatogenous retinal detachment. And this is a taut posterior hyaloid following a proliferative diabetic retinopathy, producing fibrous tissue and contracting the macula. And then you have this, once upon a time, rubeus iridis associated with vitreous hemorrhage was a contraindication. Nowadays, I give intracameral anti-VEGF, and a day later, I do the vitrectomy and do an extensive pan-retinal photocoagulation. Earlier, I was also adding the cryo, but now I don't do, and because of the wide angle, you can do up to the ora. And in case you can't see periphery, you can TIPRESS, and even in a phakic eye or a pseudophakic eye, you'll be able to go up to the periphery and do as much as of laser possible, and also add anti-VEGF same day. Even though you're given a day before, usually we expect the things to get, even though there can be a systemic absorption, and systemic absorption takes over a period of a few days. So I think the next day you can add it as a severe eye, otherwise they will result in severe neovascular glaucoma. And diabetic blindness, the diabetic macular edema, traction retinal detachment, and neovascular glaucoma are the conditions where we can do vitreous surgery. We know all this, but in spite of that, vitreous surgery is required. And vitreous surgery is to restore, maintain vision. The surgical objectives include thorough removal of the blood, end of photocoagulation, and reattachment of the macula. So here we have a case 1, a diminution of vision in both eyes since 2 days. He's a diabetic since 11 years on insulin, on poor glycemic control, came with blindness in both eyes, only vision counting finger close to face. On examination, he had vitreous hemorrhage with diabetic traction retinal detachment in both eyes. Right eye followed by left eye vitrectomy was done a week apart. And here you can see the vision improved to 618 after 6 weeks. You can see the phakic eye, and usually I don't like to do a combined at that stage because in a diabetic eye, still the lens acts as preventing the posterior vascular growth factors to migrate to the anterior segment. So if you have the lens in position and then do the vitrectomy, and then in case the cataract becomes more, and you can plan for a cataract with IOL. In some eyes, you use silicone oil where it can be combined with silicone oil removal. You can see the vitreous hemorrhage is removed, and then now the tangential traction is being relieved, and then you see the fibrovascular proliferation. I'm doing endodiathermy to make sure that bleeding does not happen. And I always keep the pressure on 20 and operate, because diabetic eyes, there's a possibility of optic disc becoming pale. And you see, in spite of the diathermy, there is some ooze, but I think you can again trim it and then use the diathermy to diathermize the bleeding fibrovascular proliferation. And the whole idea is to remove the anterior-posterior traction and the tangential traction. Still some retinal hemorrhage happens, and which can be cleared using the retinal brush. And in the previous to the anti-VEGF era, and we used to have severe recurrent bleeding as one of the causes for vitreous lavage or OPD fluid air exchange, which is a multiple procedure needs to be done. Now, giving anti-VEGF pre-op, then vitrectomy with a gas and laser, I think the chance of recurrent hemorrhage is usually almost minimized to 5%, and then more. Even the 5%, you may not need a vitreous surgery, because the advanced vitreous surgery clearing all the traction and make sure good endolaser photocoagulation done is actually grown. And this sort of eyes where blindly you cannot give anti-VEGF pre-op, so we have done the vitrectomy, and at the conclusion we give the anti-VEGF, so that and again at the end of 1 month if required, performing OCT and angiography. If need, you enhance with further laser photocoagulation as well as anti-VEGF injection. So you can see fluid air exchange done, and that's the advantage of using the biome, where you can, or any other wide angle, where you can work under the air. And so because the view is so good, and particularly using the 3D. Here you can't demonstrate that, but using the 3D, you'll be able to see well. And only another advantage of using the 3D is whatever you see, all in the OT, including your assistants, can see. And this is the case to proliferative diabetic retinopathy with a preoperative visual acuity of 2/60 with a fibrovascular proliferation, as you see here, and post, and this is the intraoperative. You'll be seeing this is a 25 gauge vitrectomy, and I make sure I do this tangential entry so that the wound closure is, wound construction is very good. Here you see the fibrovascular proliferation, and again relieving all the anteroposterior traction, tangential traction. And I use the vitreous cutter itself and remove the pre-retinal hemorrhage with a, and here I'm actually using the proportional mode in between, where I actually push the fluid between the membrane and the retina. So that the idea is, this is what is a proportional mode, where you can push the fluid between the retina and the fibrous tissue. It takes a little more longer time, but only thing you don't have to exchange instruments. You can also do a bimanual surgery. Again, I think I don't go with the idea of doing only this technique. I do depending on the eye. And then here you see, after making a cleavage and making a fibrous tissue a little more mobile, I make much space and then go to the convex side of the fibrous tissue and then do a cut and trim that. This is what I meant as convex side, so that you keep on trimming, and thereby you can remove the fibrovascular proliferation which is adherent to the retina. Only thing is you can see that again I'm using the proportional mode to push the fluid between the membrane and the retina, and you can see the membrane is extending from the disc to the periphery, and then here again I'm doing the same. You can see the fluid being flushed between the membrane, and you saw the blood gushing out. So it's actually creating a cleavage, and I think it's like using a gush of water as a blade of knife. And you can use the pre-retinal hemorrhage to clear the pre-retinal hemorrhage which happen, and then do a fluid exchange. And because repeated bleeding happens, and you can see that the view is hazy, but you can do a thorough endolaser photocoagulation and replace the eye with gas. There is some nuclear sclerosis. We can wait and see. Usually the patient's vision improves, and there is a patient has improved. Disc is failed, all membrane is removed. The visual acuity is 6/9. This is the third eye. We had a combined retinal detachment with the cataract in a proliferative diabetic retinopathy. I have Dr. Kavitara who does the cataract. I don't do cataract, and she does the phaco with the intraocular lens implant, and then I take over and then do the cataract. I do the, she does the cataract, removes the cataract with the phaco, and then introduces the foldable lens. And then after that, I take over and do a 3-port pars plana vitrectomy. And all this is, you can do a sutureless. Even if you do a belt buckle, you can make scleral flaps. We use the vascular sleeves, so there's no sutures at all. You can do a cataract, vitrectomy, and belt buckle totally sutureless. And I think modern surgery aims at airtight prototype surgery, and you can also you can see there are multiple entries made, and I think the advantage is that you do everything in a micro way, so that the wound healing is better, handling of the eye is much better, so the inflammation is much less, and many times the next day the eye does not look like it's operated, and that's where you learn tissue handling and also tissue care, including conjunctiva. And then here she's introducing the foldable intraocular lens. And the advantage of using the 3D RTO is the surgeon like Kavitara sometimes doesn't want to use the 3D, but she uses the binoculars and the microscope, because you can have the binoculars up when you're not using the 3D, but the recording will be in 3D. And now I take over and make a 23 gauge entry and do a 3-port pars plana vitrectomy after the lens is in place. And then I do the anterior vitrectomy, posterior vitrectomy, and then clear the vitreous hemorrhage, and then if the traction. So all the vitreoretinal procedures are done, and so you can see now the vitrectomy is in progress with the organized vitreous hemorrhage, and you can see there is a fibrovascular proliferation on the nasal to the optic disc. So the airtight, watertight incisions done. The cataract helps in the and also making the port. You can make the port. And if here I'm doing the diathermy of the fibrous tissue, you can see a rhegmatogenous combined retinal detachment. So I'm also diathermizing the edge of the break. But right now I'm diathermizing the fibrous vascular proliferation, and I'm delineating the fibrous tissue from the retinal detachment. So here you see there is some amount of subretinal blood is there, which I'm also removing. And you can use the vitreous cutter, use the suction and remove the blood. And this is, I think, a fresh blood which has happened in spite of diathermy when you're doing. And now the entire subretinal blood is removed. The adhesion between the fibroscopic proliferation and the break is also severed. And now I'm again dissecting the fibrous tissue and the near the break, and you are seeing pre-retinal hemorrhage which has happened, which is also I'm clearing using the vitreous cutter. And I am diathermizing the edge of the fibrous tissue and the break so that the attachment can be severed so that there's no traction persisting after the completion of the vitrectomy. Here I'm using the vitreous cutter and removing the pre-retinal bleed. So that the idea is not to get out instrument, put a vitreous brush, the backbrush needle, but you can use this. You can see now I'm clearing, and this is again diathermizing the fibrous tissue. And the reason I've done the diathermy around the break is to identify the break, because once you do a fluid air exchange, many times the break is totally closed, and then break becomes smaller and you will not be able to identify. So this you can see, and I'll be doing an endo laser between the around the break as well as between the break and the retinal break, so that the in between retina is totally laser. And here again, I'm magnifying and identifying the fibrous tissue and severing the connection between the fibrous tissue and the retinal break. So finally, the fibrous tissue is almost trimmed, and there's no traction on the break. There is some ooze happening. I'll do a diathermy. So now you can see that I'm severing the attachment, and it's all away from the optic disc, because you have to be careful when you are actually diathermizing near the optic nerve, because it can produce optic disc pallor. No point in doing an extensive vitrectomy and having an optic disc pallor. So I'm using PFCL up to the fibrous the break, which is in the nasal side. I'm now using the PFCL as a third hand, and then using a vitreous forceps to grasp the membrane and sever the attachment. So I'm judging the how adherent it is by lifting the fibrous tissue. So now I was able to remove the fibrous tissue en masse, and you can see I'm having the PFCL, and then using the retinal brush, I'm going into the retinal break and doing an endodrainage and fluid air exchange, and so that the entire retina is flat, and you can see the retina between the optic disc and the break is also flat, indicating that there is no traction, and the PFCL makes sure the retina is flat. And then you do make sure the entire retina is subretinal space and the periretinal area is dry, so that the entire eye is filled with the air. And under air, you can do the endolaser photocoagulation. And being with so much of traction and then present, and I prefer to use a silicone oil. And I thought if there is and then we can remove the silicone oil later once the eye is stable. And I'm doing using the curved probe, the endolaser under the air. And here I'm doing the laser in the in-between retina, between the break and the optic disc. And you should do a thorough pan-retinal photocoagulation, except the optic disc and the macula, so that all the anoxic retina is ablated, so that the need for the oxygen content will be less, so that the optic disc and macula can function well and the patient can see well post-vitrectomy. Because I'm completing the endolaser, and then finally removing the PFCL which is there. This is again at the completion of panretinal photocoagulation. I think this eye I didn't use oil. We left the eye with the hair and a pseudophakic at the end. And this is a final video, I think. It's a twin light vitrectomy for proliferative retinopathy, which allows excellent illumination. And this is a very old video. I'm just showing managing the complex proliferative diabetic retinopathy. You saw Dr. Cyrus Shroff technique. You saw the previous cases. And now this will be a bimanual. I'm using a twin light designed by Class A Cart from Frankfurt. And the idea is that it gives a beautiful illumination. Nowadays, you can use multiple Paul-Tornam as chandelier illumination, single light probe illumination, which can be illuminate. It's like illuminating the whole hall with one halogen light. So here you see using the curved vitreous scissors. I'm using the forceps to pull the membrane, identify the cleavage, and then dissect the membrane slowly so that we can remove the membrane en masse. And every time, even though it looks fibrous tissue, but in fact there's some vascular element which is there because of the long-standing fibrovascular proliferation, which can give rise to oozing. And in these sort of eyes, if you use anti-VEGF pre-op, there is a risk of traction increasing and producing a problem. So you can avoid anti-VEGF in these sort of eyes, and you can use the surgical maneuver to remove the membrane. It needs meticulous dissection and patient surgery, and a persistent and a precise surgery is required. So I'm even segmenting and then delaminating and then finally removing the tissue bit by bit, but maybe en masse. And then you can remove the tissue for studying also using the microscopy for electrohistopathology. So you can see the membrane can be removed this way, and then the entire membrane is being, and there is some ooze happening. If it is a mild ooze like this, you can wait. But if the ooze is keep happening more, and if you don't remove it in between, there's a possibility sometimes the blood gets stuck with the retina, and then removing that becomes a problem. So better to remove the blood in the controlled fashion. And here the ooze has stopped, so I'm waiting and proceeding for the blood to get clotted, and then remove it at the end. And here you can turn the scissors and you can remove the membrane. You can see almost all the 90% of the membranes are removed. The last part is being removed, and then so I think in the 90s, the 19 to 20% was the risk of iatrogenic retinal breaks, and now I think it has reduced to the minimal, and that's because of advanced illumination, advanced viewing system, as well as advanced vitreous surgery and micro instruments, which makes the complications lesser. We can't say complication is zero, but complication is lesser, and the least complication is what a surgeon should aim. And here is another bad traction retinal detachment, again using the same technique, using catching the membrane and then removing. So I think that depending, and here you see the membranes are being removed, and most of the membrane is removed, and then you can use a PRCL and an endolaser PRCL air exchange. And many times in these sort of eyes, when the retina has been lifted for long, I prefer using the PRCL to flatten the retina, do the endolaser, and then do the air oil exchange. So the favorable preoperative factors: short duration of macular detachment, limited extent of detachment, presence of preoperative panretinal photocoagulation, absence of vitreous hemorrhage. And a favorable preoperative visual acuity 5/200 or better, absence of rubeosis, absence of retinal detachment involving macula. Unfavorable are macular detachment and combined retinal detachment, and that's the patients you saw. Now, even in that, I think the 3D vitreous surgery for PDR is very good. 3D vitreous surgery is a revolutionary technology to change the way a surgeon performs VR surgery, benefits both the surgeon and the patient, and can be widely accepted platform. And the posture, which Dr. Cyrus mentioned, this is a 3D Ingenuity by Alcon, and I don't have any financial interest, and this is RTO. It has the digital optics, ad vision, cloud connectivity, hybrid mode, auto adjust, and it's the first digital microscope, the new era of visualization in ophthalmic surgery, delivered by the first digital hyperoscope, and without compromise. And it has the digital evidence, which is outstanding. Ad vision has a digital assistance. I don't have the OCT, but we can have the OCD and the cloud connectivity. And this is an auto adjust, which you can see, and this is how the system works, and you can see the brilliant OC there. And then this is a hybrid model. And then advantage of the experience of the posterior segment surgeon, best combined with for the surgeon's neck remains relaxed, but I feel exercise is important, and the posture at the microscope.
Sorry to interrupt, doctor, but could you please wrap up in next 1 minute?
Yeah, I'm doing that. And then it has a good adaptability. It's an advanced teaching tool, and that's what I'm enjoying using this. Now I'm trying to talk with the cyber side how we can transmit the 3D vitreous surgery. You see the entire operating staff can see that, and whatever you're seeing, you can. So I think we have to screen so that we can. This is my the 3 generations of ophthalmology. So thank you very much for a patient listening. Thanks to my fellow.